All right, so this video is going to be on how to try in a crown. You see, when a patient has a crown prep done, they leave with a temporary, and then they come back, and we take the temporary off, and then we have to try in the crown, make sure it fits well before we actually cement it into place. So this video is going to be on that point where the patient comes in to the point where it's ready to be cemented. So let's kind of go over what those steps are going to involve. First of all, the steps here is to, of course, remove all the cement. All the cement has to be off the tooth first. Then we have to verify that the crown actually is seated down all the way and the margins are completely flush. Make sure that the interproximal contacts where you floss the teeth, make sure that those are present and not too tight. And make sure that the bite feels good, that the crown fits into the existing occlusion of the patient. And then, of course, make sure that the shade is correct. Some points of safety, though, to kind of go over. This crown, it's just kind of sitting loosely on top of the tooth, and we'll make sure that that doesn't inadvertently come off, and then the patient maybe choke on it or swallow it, or even worse yet, aspirate it. So let's go over some points of safety real quick. While taking the x-ray, be careful when you're putting the x-ray holder in there that you're not knocking the crown right off the tooth. You may not knock it off completely where the patient maybe would swallow it, but you might knock it off a little bit, adjust it, and so you're going to get a false reading on your x-ray. Also, for upper crowns, I find that just have the patient turn their head to the side a little bit. So in case it does fall down, that it goes into the cheek, under the corner of their mouth, not, of course, down their throat. For lower crowns, I might even tilt the patient up a little bit. That's going to, again, have gravity not work against us so much. Also, don't leave the crown in the patient's mouth any longer than necessary. Let's say you're trying something in and you need to go grab an instrument or something out of sterilization. Take the crown out and put it to the side and then go get what you need. Don't just leave it in there, because the patients, when you're out of the room, they might start using their tongue and kind of feel around, and they may knock it off. Also, when you're going to be checking the occlusion, you're using some articulating paper. You're going to have to dry the surface off. Make sure that when you're drying it with air, that you don't blow the crown right off of the tooth. And just always remember this, gravity is your enemy. So just do whatever you can to mitigate the crown coming off and then, of course, going down the patient's throat. When removing the temporary, at least in our office, we're going to numb up patients ahead of time. That just makes for a much easier appointment for the patient. I know they a lot of times don't like to get numb, but the idea of washing and drying and scraping on a tooth while it's not numb is not very pleasant either. So when we remove a temp, we're going to either use hemostats. We're going to go in and just kind of pull it off. We may use a spoon and get underneath the margin and try to pop it off. Or if it's on there really tight, we're going to cut it off by having the doctor would go in with a high speed and cut buccal, occlusal, lingual, kind of creating a distal and mesial half. They'll put in an instrument and just kind of wedge that little slot apart, allowing the crown to pop right off. Again, this is one of those things that you want to be very careful, especially when you're holding on to a crown with a hemostat. You're applying pretty decent amount of pressure when you're trying to lift that off. And I always kind of think about it like this way. Imagine trying to handle a wet marble with pliers over an open sink drain and hoping the marble doesn't go down the sink drain. I mean, that's kind of what we're dealing with here. If you're going to use a spoon excavator to try to pull or try to pull it off, you may want to put your finger over the top of it. So when it does actually give way, again, it doesn't go flying up into the patient's mouth and go down their throat. So just some points of safety right there. Now we get to the point where we're actually going to be removing the cement off the tooth. We're going to either go with a hand scaler, like a scaler, or we're going to use like a piezo electric unit, where that's going to help remove it a little bit more efficiently. Now we're going to make sure that the cement is completely off, and how we do it, we have to dry the tooth in order for that to really show up. If you have saliva or water on there, sometimes that camouflages the cement and you can't really see it. And I find that the most typical areas that assistants miss, and even doctors to some degree, is on the mesial and distal walls, because it's just harder to see between the teeth when you're trying to get all the cement off. So let's go over a couple of examples here on what that might look like. So here is what we see. This would be missed cement. Again, you can see this one's clearly on the lingual, but over here, this is along the margin and right here on that one wall. And again, if that was wet, you probably wouldn't see it. And even though I was able to get this big camera in to get this photo, you can take your small camera and mirror. If you take your small mirror and move it around, you'll be able to see this, but it has to be dry in order to really see it. Let's look at some other examples. Here is actually, this is a lot of cement that's been left over, but you might actually see some cement still stuck underneath the gum line. If the patient came in during the crown prep, if they had a large MOD or a large, subgingival area of decay, when you got it all cleaned out and made the temporary, sometimes the temporary doesn't go all the way down, and in which case the cement kind of oozes against the tooth. It might even go down some inflamed gum tissue. And so that may have been stuck there the entire time the patient was wearing the temporary. And so when you're cleaning up the cement, you also have to look around the gum line. You can imagine when you pick out that subgingival area of cement, that area is going to bleed. So you will need some kind of astringent agent, some kind of styptic agent in order to help stop that from bleeding. But make sure all the cement is completely removed. So let's imagine you've removed the cement and you go to try on your crown and you take an x-ray. You'll see right here, what is this going on right here? This is actually temporary cement that's been left over. Again, that looks like it was subgingival. The assistant missed it. But when you take the x-ray, it shows up very clearly. That obviously needs to be removed before you can, cleanly put this crown into place. Here's another example of some cement left over right there. It can just be this little tiny fleck of cement. Let's go over path of insertion. Now, a lot of times you just think a crown is just going to go straight down on top of a tooth. And I'd say about 97% of the time that's what happens. However, there's a few times where the patient's neighboring teeth might be a little bit off center or not lined up along that quadrant. And you may end up having to roll the crown in. Either you're going to roll it from the buccal or roll it from the lingual, but that's another way that you may have to get a crown in completely. If you just insist that every crown must go straight down, you may make some adjustments and then end up creating an open contact. So there's a reason sometimes labs make a crown roll from one side or the other. If you're having some difficulty in trying to just get it down the traditional way, try rolling it in from either one of those two sides and see if that helps. As a side note, what happens when you have a patient who comes in with one of their own crowns that have come off? They usually show up in the office with the crown in a little baggie, and they say, I was eating something chewy last night, and it just kind of came right off, and now they want it re-cemented. You're going to go through the same steps that we're going through right here in getting that crown ready to be seated. You're going to first make sure all of the cement. Well, first of all, the doctor has to take a look to make sure there's no other underlying problem. Assuming that the tooth doesn't have decay or a fracture or the buildup is still in place, assuming it's going to be re-cemented, then you have to make sure, again, the cement is off the tooth. And in this case, you have to make sure the cement is off the interior of the crown completely. When that is all done, then you can move on to put the crown on top of the tooth to take your x-ray to determine its fit, to make sure it matches up with how it used to fit on the tooth. So again, a patient's own crown, remove all the cement on both the tooth and the crown before you attempt trying to see if it still fits. We want to verify we've got complete seating of the crown. Now, you're going to first look, when you put it in, look on the buccal, look on the lingual, and that will give you a pretty good idea if it's down all the way. If you don't see it down on the buccal or lingual, that's where you have to kind of address first. Make sure that you can get that tooth to kind of nestle into place. And then the x-ray, when you put the crown on without cement yet, you're just testing it, you're going to make sure that it has a nice tight seal all the way around it. Like, for example, here's a PFM crown, and it, you can tell, has got a very nice seal. Here's what might be called an EMAX crown or a lithium disilicate all porcelain crown, and it too has a very nice fit right there. What you're looking for is a very nice, tight, no open gaps, nothing overhanging, just a nice, smooth, flush fit. Let's see here. But sometimes they don't go down all the way, and you have what's called an open margin. That means the crown hasn't gone completely down on top of the crown yet, so it cannot create that nice seal at the margin. So what are some causes of an open margin? Well, it could be the incomplete cement removal, like we talked about just earlier. If you have too much cement still in there, it's going to block the crown from actually physically going on top of the tooth. You could have gum tissue that, in case your temporary was trimmed a little bit too high, creating an open margin on your temporary. Gum tissue may have actually migrated into that space. And so now when you take that off and now you go try to put your final crown in, that gum tissue is just getting squished between the tooth and the crown. Or it could be that the neighboring teeth, one or both, is keeping the crown from going down. It's kind of running into an interference, an interproximal is too tight. Or it could be just a problem with the lab. Maybe everything is great as far as it's fit between the teeth and there's nothing in the way. It's a nice clean margin. It just doesn't reach all the way. It could be a problem with the lab and how either they drew the margin, how they trim the margin. It could be on their end as well. So what is this? So an open margin, what does it look like? Well, when you look intraorally, it would be what you would imagine. There's a gap between the tooth and the crown. So you can tell a difference. This is open. This is closed. This looks really good. That needs a little bit more work. You got to try to investigate to see why isn't this crown going down all the way. When we take an x-ray, we can see how that can play out as well. But the x-ray has to be taken just right. For example, on this patient, we're trying in tooth number 14, and the assistant put the crown in and took the x-ray, but you can tell the x-ray is just a little bit overlapped. Like this premolar is overlapping this, and this molar is overlapping that. You can't really see if that is completely sealed all the way. It looks okay, but there's no way of really telling from this x-ray. Same patient, we just took the x-ray, tilted it a little bit different direction. Now it shows there is actually an open contact. It's a small area, but it's there. And so that made it better and more accurate for us to get a correct fitting crown. So here's that same case, just kind of blowing it up. That's considered an open margin. You can see how the crown's coming along, or the tooth is coming along. Right here is where the crown should be beginning, but yet the crown is right there. And so those two are not joined. Here, same kind of thing. They're just not quite sealed all the way. So with the same patient, we went ahead and did some interproximal reduction, and now the crown slid in and it got much tighter with the fit. Here's just a couple of other examples. This would be considered an open margin. I throw up these examples so that you can kind of see, when you're trying to make some decisions chairside, what this is. So that would be considered an open margin. This would be considered either leftover cement that may have been from the temporary. Say you're trying in this crown, this could be leftover cement. This could be leftover cement from this crown when it was originally prepped, or it just could be some tartar that was left on the tooth from the patient not having a cleaning. So these are different things that you're looking for when taking your x-rays to determine fit. Another example, this again, slightly open after some adjustment. Now it's closed. Open, closed. Now I think call it skinny margin. So you can have an open margin or you can have a skinny margin. Okay, an open margin is if the crown's adjusted properly, it will fit all the way down. A skinny margin is where the crown's actually already on top of the tooth. It can't go down any further. It's just more narrow than the tooth that it's sitting upon. So here's an example of a skinny margin. Here's where the margin should be, but this tooth is down all the way. You can't vertically push this crown down any further and somehow make this reach over and touch that. So this is what we call a skinny margin. And this can be done because the lab may have trimmed the die too tightly or over trimmed it. It could be from a faulty impression or a bad scan that the office gave to the lab. There's a couple different reasons why that can exist, but a skinny margin, although closed, is probably not ideal because you can imagine things will get caught right there if you cement it into place. Again, here's like a grossly skinny margin where this is really hanging off the side. This is just completely not going to work at all. Here's one, I just kind of got this off the internet. Thankfully, this isn't one of my cases, but this would call an overhang. This would be the opposite of a skinny margin. This would call it a fat margin if you want to call it that, but it's really, it would call these overhangs. Okay, you can imagine if the patient tried to come down and floss, pull it forward, go down, pull forward, then pull up, they get hung up right here. And just all kinds of things could be hanging out inside this little overhang, which would lead to all kinds of gum inflammation. You can tell that this patient, of course, this isn't mine, I don't know the history, but they've been through a lot of attempts at trying to fix their teeth along the way. And so this would definitely be a big no-no. You cannot move forward with a crown like this. There's no fixing that. Here's an example, although it's a bridge, that's an overhang on a margin as well. Okay, so now we're going to talk about how are you going to actually adjust the interproximals to allow the crown to sit all the way. So what we use in our office is going to be, if it's a porcelain crown, we're going to use a diamond burr, a fine diamond burr. And before we do any adjustments, let's just verify that it actually needs to be done. One, if there's an open margin, there's no other reason for it other than the contacts, that's when you would adjust it. But when you're checking it, if you're really good, you can do this by yourself, but if you can have a second set of hands in the operatory when you're doing this, it really helps if you can have someone hold the crown and then someone else actually does the flossing. That's going to tell you where really if you have a really tight contact. And again, everyone has flossed their own teeth. They know about how much tension should be on there. Just because you can really force it down doesn't mean it's a good contact. It should just pop through like normal. Okay. Again, going back to if we're going to adjust it, what we're going to use, it's going to be a fine diamond burr. And again, we just want to make sure the gums are not causing the open margin before you start adjusting. A couple of things about adjusting a crown. A lot of times we're just going to go in and just adjust the mesial wall. You can kind of get an idea where it's kind of rubbing. But when you're making these adjustments, there's something you may want to consider. Let's go through this as an example. So here you have an open margin. You have the point of contact is right there. There's your gap. There's your open margin. Let's see here. Okay, you apply pressure on top of it. The gap is still there. Sometimes when you're taking X-rays, you may even put a 2x2 or maybe a cotton roll on top of it while the patient's biting, just to make sure it's got a nice positive pressure all the way down on top of that tooth, that they're not biting on the sensor and somehow rocking the tooth out of position. Although you should be able to feel that with your finger. Okay, right here you check it with the floss. Again, you determine that it's tight. You need to adjust the contact. And so when I'm adjusting the contact, sometimes what I'm thinking of is that this crown needs to kind of roll into position, or it needs to kind of slide forward. I might favor the more gingival part of the contact as opposed to the occlusal part, because that's where that's the initial point of contact is. And if I adjust a little bit here, there might be just enough to allow the crown to finally fit into place. If I adjust too much, of course, I run the risk of creating an open contact. So sometimes it just takes a couple different attempts. Usually it takes me, if I have a really tight contact, maybe 3 or 4 different adjust, try and check, adjust, try and check. And when you think you have about right, that's when you would take the X-ray. So right when you have it all done, this gap is going to go away, and you're going to have now a nice margin that's closed, and the floss still pops. Okay, what if you're trying in a crown and it has a buccal lingual rock to it? That means that probably both the interproximal contacts are too tight. So here's an example of a case where here, this is what it looks like. I mean, that's an excessive buccal lingual rock. And so you can imagine, you can just picture in your own head that the mesial and the distal contacts are the things holding up that crown. So both of them would have to be adjusted. You would not just adjust one and try to get that one just right and then try to do the other one, because they're both kind of working against each other. So you kind of have to do a little on both on every time you're trying it in. So what happens if the crown comes back and there's an open contact, or maybe you adjusted too much? And now you have this open interproximal contact. Well, if you put it in as is, well, you can imagine it's going to pack all kinds of food in there. And if food is left in place, the patient's going to eventually wind up with decay, which is what you can see what happened right here. Implant, regular tooth, both crowns, open space. Clearly, you can see food would go right down here. It stays down here. And now you have a food trap issue. So it has to be fixed. However, you can't really fix those chairs unless you have some kind of oven in your office where you can add a little bit of porcelain, bake it, and then go back into the room and try it back in. Most offices don't have that. I would say in our office, if you've gone through the steps, you've made sure at this point that the crown is truly down all the way, that the margins are closed. I would check the occlusion, and I would make sure that that's good, because if you're sending back a crown, because it has to be sent back to the lab because of an open contact, why don't we check the other things too? Just make sure that it's fine. Make sure the only problem with the crown is an open contact. If you send back the crown and you haven't verified that the margins are closed, imagine this. The lab gets it, they add some porcelain, they send it back, you try it in and it has good contact, but now you take an X-ray and determine, oh, it has open margin. Now you have to send it back again or redo the crown at that point. The patient may not like that so much. So if you're going to have to send the crown back, make sure you also check the margins and that you check the occlusion, because if you have to adjust the occlusion, do that right now so that when you send it to lab, they can polish it up so when the patient arrives next time, all you're dealing with is an interproximal contact. So now let's talk about occlusal contacts. I actually created a video. It's on YouTube. It's called Occlusion for the Dental Staff. And this is a 8-minute video. And it goes through how we determine where you should adjust and where you should not adjust. So I'm not going to play that right here, but just know that that's a reference for you. But when we're checking the bite, we're going to be using articulating paper or shim stock. In this slide, I'm showing 2 different kinds of articulating paper. One is going to be kind of the silk style that you're going to use this holder. That's what we use when checking porcelain crowns or any kind of crown or bridge. The other kind is this kind of paper material, and we use these more for night guards, not so much to check on porcelain or to check a crown. In order to do that, however, the tooth has to be very dry so that it comes out with a very accurate marking, kind of like this right here. That's a very accurate mark. And so that tooth was dried off, I can tell, prior to using it. And they come in blue, they come in red. Those are the typical colors. You can also use shim stock as a secondary way of determining if you have the right occlusion. How this works, it's this real thin, it comes in a roll, it's a very thin little ribbon. You put it on some kind of holder, we usually use like a hemostat, and we put it in and we check each tooth in the quadrant. We do it with the crown out and we do it with the crown in. And the other teeth should have the same bite grip on that little ribbon, that very thin ribbon, whether the crown is in or out. You can imagine if you have the crown out and they bite, in this case, let's just say it's the second molar the first molar is where you're putting in, you're trying in the crown. You go back and you put the ribbon on the second molar. Remember, the crown is out, they bite down, and the articulating, the shim stock is actually gripping. Okay, now you know the second molar is in contact. You go put the crown in, have them bite again, check the second molar, and if that paper slides out, now you know the only variable you changed was the crown. That means the crown is propping open the bite and is not allowing the other teeth to come together. So you should use the shim stock and check each tooth in the quadrant to make sure that it's gripping whether the crown is in or whether the crown is out. And like I said, it has to be very dry prior to checking it. So we use dry angles and we use cotton rolls to make sure the field is completely dry. Even the opposing teeth need to be dry so that when they bite down. And when the patient bites, a lot of times saliva will kind of flow into the field. So you have to make sure all that stuff is out of the way prior to checking the bite. So we'll go through real quickly. Here's a case that came in that the patient was hitting too heavy on. And I went through a series of photographs where I put it in the patient's mouth, had him tap, tap, tap. I took the crown out, put it on the model, took a picture, made the adjustments, went back into the mouth, tap, 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 the same kind of process. And you'll see I went through several of these before I finally got the bite settled in just right. And again, a lot of this has gone over in the other video I referenced earlier. But here, even though you see red marks in several locations, just from experience, I find that the incline of a cusp, so here's the cusp, here's the fossa, between there's this incline. Typically, I will start there with my adjustments because that's usually the problematic area. So you can just see from here to here, this is where the contact is probably holding up the bite the most. So then, like I said, I made some adjustments, went back into the mouth, came back, took this next picture, and you can see that those marks are still there, but they're getting a little bit smaller. Go to the next one, and now those have kind of gone away, but now you can see the marginal ridges, they're starting to come into the picture now. Those are the next high spots that need to be adjusted. And so as we keep going through these slides, you can see that the marks are getting smaller and fewer in number. And when it gets to the end, this is kind of the final markings. Although, yes, there is still red markings there. Those markings are false positives. Those are not truly contacts that are holding up the bite. Because at this point, the patient says it feels good. Even though they're numb, they can still feel that their bite's coming together correctly. And so here it is showing where it started and where it ended as far as markings are concerned. And then we've got it polished up and it's ready to go inside the mouth. Actually cemented that crown into the mouth, checked the bite again. And I wish I had the photo, but when I put the crown in before I did the adjustments, this second molar had no red markings on it at all. After I got this adjusted to fit into the bite, that's when these red markings started to appear. So that just is a confirmation that the crown has been adjusted correctly. You can also check it, I guess, with the crown out, check with the paper, and then, of course, go in with the crown and check with a different color paper. That would tell you if there's a match or if there's a mismatch there. And I guess the other way, if you didn't have two different colors of paper, you could put the crown in, make sure there's no red marks at all, have them tap, look inside, look at the neighboring teeth, remember what that looks like, take the crown out, have them bite again, and go look immediately with your mirror and see if there's a mismatch from what you just saw from what you're now seeing after the second tap without the crown to see if there's a difference. Anyway, let's go over those steps one more time to wrap up this video. First of all, make sure that the tooth is cleaned, make sure the margins are closed, make sure that the interproximal contacts are present, and that the occlusion is in harmony and that the shade blends. If you can get all through all of those steps, that crown is now ready to be seated, of course, after it's been polished. All right, hopefully this has been helpful, and thank you for watching. Take care.